So I'm going to do is I'm just going to talk about what is the need of liver transplantation, what are the indications, contraindication, how do we evaluate a recipient and a donor for liver transplantation, and then we'll just touch on some of the aspects of the operation, that is DDLT means disease donor liver transplantation and live donor transplantation as well. So just to check on the reality, so nearly 250 to 300,000 people actually die of end-stage liver disease in India currently. This is again a very rough guess estimate because we don't have registry data to actually put the numbers or pinpoint the numbers properly. And out of this, around 25,000 to 30,000 lives can be saved if a timely liver transplantation can be done in this group of patients. And currently, about 1,800 liver transplants are performed per year in the country. Out of this, 80% are live donor liver transplantation. That is, some of the relatives or family members donate a part of the organ, and that's how that operation is done. 95% of these operations are happening in private hospitals. 50% of this are being done for foreigners because of the cost issues which restrain a lot of Indian patients having this treatment done. And 80% of this can't afford, that's what I said before. So there is a wide gap in between the number of patients who are suffering from liver diseases currently in India and who need liver transplantation and what is happening currently in India. So the only way to fill this gap is to have a low cost cadaveric liver transplantation in the country that can actually fill the gap. And we're going to touch on how we can fill this gap in the country currently. So all is not that bad. So number of liver transplantation has been increasing over the time. And over the last decade had seen quite a in terms of number of transplantations which are happening. And the blue line is total and the red mark actually is DDLT. So again, suggesting that predominantly the activity is live donor liver transplantation in the country. And we need to change this so that if more and more organ donation happens, then more lives can be saved and the number of transplantation can be increased. So there are 90 centers. Actually, this may be around 150 centers. We are now the highest number of live donor liver transplantation in the world. And the training has become available locally. So a decade ago, people will have to go abroad to get trained and then come and establish programs. So those things have changed. There are lots of training centers which have come up, and ILBS is one of the pioneers in those. And now new programs are starting almost in every state as well, and every second, even in second and third tier cities as well. So this is our own activity. We do about 100 transplants a year. We touch now 900 transplants. Again, predominantly live donor liver transplant, but we've done around 70 cadaveric liver transplants as well. And we do quite a lot of pediatric transplant as well. So the number reaches around 120 of that as well. And one of the things which have been seen is good survival, which can be achieved with this life-saving procedure. And the 5-year survival actually goes beyond 75% now. This is our own data as well. So coming to indications, so this is just a general list of liver diseases which a person suffers. It can be an acute liver failure. It can be an acute or chronic liver failure. It can be a chronic liver disease like you all are aware, cirrhosis. Then it can be malignancy of the liver, that is the commonest is hepatocellular carcinoma. Then there can be metabolic and congenital liver disease, which happens in pediatric population. So coming to chronic liver disease, you all are aware about the causes of chronic liver disease. So it can be a viral hepatitis like hepatitis A, B, C, E. Then alcohol has become a big menace, and we are seeing more and more patients suffering from alcoholic liver disease. Cholestatic liver disease, again, it can be a primary biliary cirrhosis or it can be a primary sclerosing cholangitis. Then autoimmune liver disease, then fatty liver disease. This is again the combination of NASH and alcohol is a sort of become endemic in the country. More and more people are suffering from this, and we are seeing more and more patients coming with alcoholic liver disease and in combination to fatty liver disease. Or fatty liver disease in isolation is also become a very common phenomenon now. And what is happening in terms of presentation of liver disease is, on the background they will have some sort of fatty liver disease, and then they will on top of that develop an acute injury or a subacute injury in terms of viral hepatitis. So hepatitis B still remains an endemic in the country. C, although not that common in the country, but still remains. Hepatitis A, again in young group, and acute presentations are very common with hepatitis A, as long as viral hepatitis are concerned. So this is the natural history of chronic liver disease, which is you develop fibrosis, hepatitis, then you develop fibrosis, and then you develop cirrhosis. So in terms of clinical presentation, it can be a compensated disease. That is, you don't develop signs and symptoms of liver diseases. But then at some stage, this compensated liver disease develop into some sort of complications which are related to either bleeding, jaundice, encephalopathy, ascites, or formation of tumor. So any of this, if this happens, then we call as decompensated cirrhosis. And then this decompensation will lead to death in those patients. And so how this is one of the most important slide to take home actually, that what happens when you have a compensated cirrhosis and what happens when you develop decompensation. And this is one slide you should keep in your mind always, because chronic liver disease is it's a long going process. So if we don't understand this very well, then we don't actually do the treatment plans cannot be charted out. And this is a common question when a patient comes with fibrosis, cirrhosis, that how long I have got, okay? What will be my median survival? So when you have a compensated cirrhosis, your median survival is 9 to 12 years. So when we talk about median survival, so when you are seeing 100 patients with compensated cirrhosis, 50% of this will die. So compensated cirrhosis, when you see 100 patient of those, so at 9 to 12 years, 50% of this at some stage will die because of development of complication. Then once you have a decompensation, then the median survival comes down to 2 years, and that depends on various stages of decompensation. So whether it is variceal hemorrhage, whether you got jaundice, encephalopathy, or ascites. And so once you develop ascites, so there is fluid in your tummy, then the median survival comes down to 2 years. Obviously, again, then it will depend on what type of ascites. It's mild ascites, which can be controlled with diuretics, then it is okay. But if you develop a refractory ascites or other complications of ascites, then the median survival will further come down. Then if you have some syndromic manifestation like hepatopulmonary syndrome, then the median survival is 10 months. If you develop a SBP, if someone develops SBP, subacute bacterial peritonitis, then the median survival is 9 months. And if you develop syndromes of renal syndromes, type 1 or type 2, then again the survival comes down. In type 2, it is 6 months, and in type 1, it is 6 weeks. So I'm not going to go in details. I think you had previous lectures on all this as well. But this is one slide you should keep in mind whenever you see a patient with chronic liver disease, irrespective of etiologies. Okay, this is how the natural history of chronic liver disease is. So what is the benefit of transplantation? So when a person develops decompensation, then the chances of their 5 years survival actually comes down dramatically. And that's where the transplantation actually changes the spectrum. So if they have a timely transplant, their 5 years survival go up to 70 to 80%. So if you see here, if you have a decompensation like any syndrome, then the chances of your 5 year survival is very less, and it will almost come down to 0%. But if you have a transplant, then it will go up to 75 to 80%. Coming to acute liver failure, it's a syndrome of sudden hepatic dysfunction in the absence of prior liver disease. So the patient is not known to have any liver disease. They have a normal liver function, and there was a normal liver, and they develop a sudden hepatic dysfunction, and it is characterized by hepatic encephalopathy. Okay, it happens in young patient. It's a life-threatening medical emergency. In patients satisfying certain criteria, the mortality will go up to 90%, and this is an indication for emergency transplantation. So, what are this criteria? So there are lots of criteria which have been described in the literature, but one of the commonest which is used is called as King's College criteria for acute liver failure. So I won't go into details of paracetamol because we rarely see paracetamol-induced liver failures in India. But non-paracetamol is the one which is common, which is associated with viral hepatitis as well. So if you have an INR more than 6.7 single reading, then again it is associated with poor prognosis. Or if you have any three, like unfavorable etiology, like indeterminate etiology or drug-induced liver failure or ATT-induced liver failure, age is less than 10 or more than 40 years, acute presentation or subacute presentation. Acute, this presentation means what is the duration from jaundice to encephalopathy. So if somebody has got the duration is less than 7 days, then it is called as hyperacute presentation, which is associated with a good prognosis. But if you have an acute presentation that is 7 days to 28 days, then it is called as acute presentation and it is associated with poor prognosis. If the duration is more than from 28 days to 3 months or sometimes it is called as even 6 months, then it is subacute presentation and it is associated with a poorer prognosis. If the bilirubin is 300 millimole, that is 17 milligram percent in our according to our labs. So if somebody has got a bilirubin of more than 17 or INR of more than 3.5. So if any three of this are present, or an isolated reading of INR of more than 6.7, the mortality will be actually more than 80% in those group of patients. So these are patients actually, they should be referred very early to the tertiary care center and especially to the liver transplant center in order to save their life. So anybody who's got hepatitis and has got an INR of more than 2, irrespective, they should be sent to a tertiary care center where liver transplant program is there, so that they can be monitored, and accordingly, if there is a need for transplant, that can be done in a timely fashion. Because if they come late, then again there are lots of problems, and the transplant results are also not good when they present very late to us as well. So obviously, once they satisfy the criteria, they need to be super urgent listed, and if they're lucky enough, like NOTO is now very active. NOTO is a National Organ Transplant Organization, and they will list the patient super urgently, and if they are lucky, they can get a liver in time, and then the life can be saved as well. So selection for a patient in transplant for acute liver failure is important, and if you have a false positive, then it will be an unnecessary transplant, because transplant itself has got a 15% perioperative mortality, then long-term immunosuppression, and a graft which could have been used for some other person get wasted as well, and it is associated, there's financial thing as well. But if it is false negative, then it can result in death of the patient. So the message here is, when you see hepatitis with an INR of more than 2.5, and there are any symptoms of hepatic encephalopathy like increased sleepiness or irritability, these are the patient, they should be immediately referred to the transplant center. So these are our own results of transplanting patients with acute liver failure. We've done nearly about 100 acute liver failures now, and the 5-year survival actually approaches more than 70%, and in CLD it is almost 90%. So this is the chart here is comparing the ones who had transplant and who didn't have transplant. Once the patient satisfied the criteria, the chart on the right side, and the green line is my marker there. Yeah. So this is the one with the transplant, and these are the ones without transplant. So once if they are in a criteria and transplant is not done, then the chances of survival is hardly 10 to 20%. So again, emphasizing that the patient need to be referred timely. This is basically data collected over the last decade at ILBS. There were 301 patients with acute liver failure. Out of this, 181 satisfied the King's College criteria. When they had transplant, the survival was 75%. When they didn't have transplant, the survival was only 10% or so. Even patient who didn't met, this is the important part of the story. Patient who didn't met King's College criteria, the survival was only 30 to 40%. That is why actually this patient need to come early to us so that we can monitor, and rather than depending on criteria in a timely fashion, transplant can be done in this group of patient. And if they survive or with native liver, that is very good of them, but timely referral is important. Coming to acute on chronic liver failure, this is what we are seeing more and more commonly, especially with viral hepatitis as well. So this is a patient with previously well compensated chronic liver disease and in whom an acute decompensation of liver function occurs due to an effect of precipitating event. So that precipitating event can be anything, like they have taken medication for some reason, they have taken any herbal medication or home remedies and all, and they had background of some sort of background liver disease in terms of steatosis, steatohepatitis, and all those things. And then because of this acute hit, they develop a sudden deterioration in liver function. So this commonly happens with middle-aged patient, high incidence with alcohol, fatty liver, drugs, and viruses. And there's a high in-hospital mortality in this group of patients. The 28-day mortality actually goes more than 50%. And again, this group of patients, if they don't improve on medical treatment, the only life-saving approach will be to do an emergency liver transplant in this patient. So this is just to summarize the natural history of ACLF, acute on chronic liver failure. So basically, they have this spectrum of development of SIRS, sepsis, organ dysfunction, and organ failure. And in the 28-day mortality, as I said, goes more than 50% in this group. And if you do a timely transplant, then the survival will approach nearly 80 to 90%. If transplant is not done in timely fashion, then once they develop organ failure, organ dysfunction or failure, then the survival is less than 10% in this. So there is a narrow window of opportunity to transplant this group of patient, and if they develop organ dysfunction or failure, then it is too late for them as well. So again, this group of patients need to be referred in a timely way to the tertiary care centers, and especially the liver transplant units, for them to have a life-saving treatment. So this is again our own data comparing ACLF with CLD, and the median and the survival approaches nearly 70% in this group of patients as well. So tumors of the liver, the commonest is hepatocellular carcinoma, and it is considered to be fifth or sixth commonest malignancy, but I would have thought that we see much more, because this is world data. We don't have Indian registry data, but I think hepatocellular carcinoma will be much more common in India in comparison to other Western countries because of the endemicity of viral diseases as well. And so in terms of hepatocellular carcinoma and liver transplantation, so basically the tumor stage plays an important part. So the more the number of tumor and larger the tumor, the worse is the prognosis. So this is a sort of metro ticket concept which was proposed from Europe. So as the number and sizes of the tumor increases, the survival, actually long-term survival, keeps decreasing as well. So obviously there is a limit about in terms of in the cadaveric setting that whom to allocate an organ. So you can't give to every patient with hepatocellular carcinoma, you can't give an organ. So you have to bound down to certain criteria in terms of whom you're going to give an organ and whom you're not going to give an organ. And that's why certain criteria have been developed. So the commonly used criteria is called as Milan criteria. And the second common is University of California, that is UCLF criteria, which is single lesion of less than 6.5 centimeter, 2 to 3 lesions which are less than 4.5 centimeter each, or a total tumor diameter is less than 8 centimeter. And if you transplant in this particular with this particular criteria, the 5-year survival actually approaches 75%. So, but the things have changed quite a lot in last decade or so. So we see a lot of patients with advanced hepatocellular carcinoma as well. They can get locorenal therapy to downstage them. Even in cases with portal vein thrombosis, tumor thrombosis, there are now effective treatments with newer drugs and you can downstage them. And once they satisfy the downstaging criteria, they can still be candidate for liver transplantation. So again, I'll say every patient who is otherwise well to have a liver transplantation with hepatocellular carcinoma should be referred in terms of an evaluation whether they can be a candidate for transplantation. And obviously, all patients with chronic liver disease currently should be actually screened in terms of whether they are developing hepatocellular carcinoma. Because if they are screened, and if you have screened them, and if you detect the tumors early, like when they are 1 centimeter, 2 centimeter, or 3 centimeter in size, then the chances of cure increases. And also there can be ablative therapies which can be offered, like non-transplant therapies, which have also got good long-term prognosis as well. So patient with viral hepatitis, especially B and C, should be regularly screened for development of hepatocellular carcinoma. So I'll say, although my hepatology colleagues might have covered this, but I'll say at least 6 monthly they should get an ultrasound and alpha fetoprotein in order to see whether they are developing any hepatocellular carcinoma or not in patient with chronic liver disease. So what are the contraindications for liver transplantation? So obviously, if you have extrahepatic malignancy, then it becomes a contraindication. Then malignancy with macrovascular or diffuse tumor invasion is a contraindication, although this is now controversial because of the downstaging therapies which have become available. Untreated sepsis is upfront contraindication. Once you treat it, then it can wait, you can do it. Again, advanced cardiopulmonary disease, somebody with low ejection fraction, or they had previous ischemic heart disease, and their performance status is not good, becomes a contraindication. Active alcohol and drug use. Drug use is obviously one, but active alcohol, because we're seeing so many young people coming with active alcohol abuse, so directly doesn't become a absolute contraindication. So if they have good family support and social support as well, they can still be considered, but then that is a highly selective criteria, and it is not like everyone will be offered, but if they have a good support system, they can be offered transplant as a life-saving method. Anatomical abnormalities, most of the time the surgical techniques have improved now, so this again has become a bit, doesn't remain an absolute. So age is not in terms of lower age. So we have done 4 months baby as well. Advanced means so 70 is common. It is common for us to offer transplant until 70. Above 70, we will go case by case depending on their performance status and cardiopulmonary status. Portal vein thrombosis doesn't remain a contraindication. HIV positivity, again, it depends on CD4 counts. So as such, HIV positivity is not a contraindication now anymore. Previous malignancy depends on what was the tumor. Supposing somebody had a breast cancer 5 years ago, it is no more a contraindication. Cholangiocarcinoma, again, in selected cases we can do. And active psychiatric illness, obviously, because they will need to remain on immunosuppression for life, so need to be carefully evaluated whether we can do transplant in those group of patients or not. So this is just to show recipient evaluation, what all is done. So obviously you have to evaluate the performance status, cardiopulmonary status. Then you have to see the extent of liver disease. So there are lots of scoring system. One is child score. Then MELD score is commonly used in terms to evaluate how much bad the liver disease is and how much is the urgency to do the transplant in this group of patients. Then all other organs need to be evaluated: cardiac, respiratory, renal, nutrition, psychiatric, and anesthetic evaluation. So how to list a patient for transplantation? So as I said, there can be super urgent listing. So super urgent is mainly where the cadaveric programs are very active. So currently in the country as well, there is a lot of activity going on from NATO, from Government of India is very keen that the organ donation should increase so that more and more patients can benefit. So super urgent listing is done for patients with acute liver failure who satisfy the criteria. Somebody had a primary non-function, so we did supposing we've done a transplant and the liver is not worked. So again, they will go on a super urgent list in order to save their life. So unlike kidney transplant, where they can just go back on dialysis, it doesn't really work with liver. You need a new liver to support it if the liver is not working. Then if they have vascular thrombosis, then they need to be delisted. And in a very, very rare thing, a live donor, if he develops a liver failure, then he can be listed for a superurgent liver transplant. So elective, this is the most important thing I want you to carry, minimal listing criteria, because most people actually find it difficult that when to refer and at what point he should be listed for liver transplantation. So anybody who has got a decompensated cirrhosis, who develops jaundice, who have ascites and related complication like refractory ascites or diuretic resistant ascites, who develop hepatic encephalopathy, who develop syndromic manifestation of renal or pulmonary, or who develop cancer of liver, which is within a criteria, should be actually seen by the liver team for listing. So that's the basic of it. All this patient, because timing is very crucial. I'll go through what timing of transplantation, why timing of transplantation is important. So commonly, what has happened somehow in the practice, it has come. There is a calculation of MELD score, model for end stage liver disease. It is available on the net. Actually, anybody can put the data in and get a MELD score, which is based on bilirubin, INR, and creatinine. So anybody can calculate that MELD score by looking at the reports. And if you get a MELD score of more than 14, they become a candidate for liver transplantation. So that's somewhat which is MELD score was actually developed in order to allocate the organ. So supposing you got 10 patients on the list who should be given an organ. So that is why MELD score was developed. So in contrast to kidney transplant, where the how long you have been on the waiting list, that decides how to allocate kidney. In liver, it is based on severity of disease, and the severity of disease is calculated by this MELD score. So if there are 10 patients on the list, how to decide whom to give the liver? So you give based on this score. So the higher your score, your priority will be higher to get a liver. So that's how MELD score works. Then there are some modification of MELD sodium. Modification has been bought because it is real that sodium is a very important component of chronic liver disease, especially in patients suffering from ascites or refractory ascites. So MELD sodium is actually got a better predictability in terms of short-term survival in patient with chronic liver disease. And CTP is used, but because it is not purely objective, so it is no more being used. So I'll just show you why it is important in terms of timing of transplantation. So this are our own patient, 45-year-old lady from Russia with CLD, hepatitis B related, along with Delta virus as well. So she had an index presentation about a year ago. She got decompensated with ascites, jaundice, and encephalopathy. Her MELD sodium was 15. She had a good performance status. Her donor was the son, and 20-year-old. So we did a left lobe liver transplantation. Graft weight was 340 grams with a GRW of 0.57. She didn't require any transfusion, extubated on table, and went home on day 14. So in contrast to what we see in Indian patients, this is a 21-year-old male from Delhi with alcoholic liver disease. He had an index presentation about 3 years ago, got decompensated with refractory ascites, jaundice, encephalopathy, and HRS. He had a MELD sodium of 32. He had multiple admissions with ascites, HRS, SBP, and hyponatremia. And this is all because of not able to decide about transplantation. So they spend a lot of money going around in terms of whether they can get better with medical treatment or not. So by that time, he developed severe sarcopenia, lost all the muscle mass. He had a poor performance status as well. Donor was daughter, right lobe liver transplantation. So again, because of the severity of liver disease, it was a long operation with blood loss of 6 liters. He got extubated in 2 days, but again developed chest sepsis. He got re-intubated, required inotrope. His total hospital stay was 35 days. So what does it mean? The first patient, actually, the actual cost of the operation was only 15 lakhs. In the second patient, the cost actually escalated on him. and it went up to 45 lakhs. So that is why timing of liver transplantation becomes very important. There's no point in delaying referring patient for transplantation, because this has got a lot of financial burden on the patient as well. Okay. Again, the limitations of MELD. So this is a patient, one of our photographs from one of our patients. MELD is 14, but you can see he's got massive ascites, refractory ascites. There's no muscle mass on him. And this is what the MELD's limitation is, because MELD actually doesn't take muscle mass or anything. Sarcopenia doesn't come into that picture. And they keep thinking that MELD is low, but it doesn't really help the patient in terms of their short-term or long-term prognosis as well. So what are the sources of organs? So in order to do a transplant, you need an organ. So there are two ways to get organ. One is a patient, somebody who has developed irreversible brain death, that is donation after the brain death, or the second scenario is donation after cardiac death. It is not commonly used in India because of the awareness as well, and people are not really aware about how the cardiac death happens. That's the limitation of that. So brain death is the commonly used, and the way the brain death system work is somebody like with head injury or a cerebrovascular accident develops irreversible changes in their brain, and their brain then again they are tested on the ICUs. There is a team of doctors which are not involved in transplantation. They do the brainstem testing, and if they satisfy those criteria, there are specific criteria which have been let down, and if they satisfy those criteria, then those people can donate their organs. Okay, so the one thing here is the patient will be in ICU, and so two important things works here. If they have expressed their wish beforehand that if they land up in the situation they want to donate organs, so if they have an organ donation card, then it becomes easier for the relatives and the medical team to go ahead with this. So that is why it is important to spread the awareness about organ donation, so that people can express their will about organ donation beforehand. So the process becomes much easier in that way. And obviously, in the ICUs, there is a separate team from transplant team. Transplant team has got nothing to do with brainstem declaration team. And in West, actually, it has become sort of mandatory that any patient in ICU should have brainstem testing, so that their trials can be done in terms of whether to continue treatment on those patients because they are legally dead. Okay. Cardiac death is patient who has sustained irreversible damage, but their heart is still beating and they don't satisfy the criteria for brainstem death. So in those cases, if the relatives of the patient agree, then the heart, the support system can be taken off. And once the heart stops beating, then there is a 5-minute cool-off period when the patient is declared dead, and then the organs are retrieved. So these are the two concepts about organ donation in terms of cadaveric organ donation. Live donation, it can be either a relative or an emotionally attached person who can donate a part of organ, because liver has got a capacity to regenerate, and because of that regenerative capacity, so we can take a part of the liver and do a live donor operation. So there is no difference in terms of survival, in terms of types of graft. Either you take a cadaveric or a live donor, the survivals are same. So it is not like the live donor is associated with a better prognosis or better survival with cadaveric. So what are the graft options you have? So in terms of either, if in the setting of cadaver, it can be a whole liver graft like this. The whole liver can be used. And sometime in even whole liver graft from cadavers can be split into two, and it can be given to a child. Portion can be given to a child and rest can be used for an adult, or it can also be split into two for two adults as well. So it can be used as a right lobe graft or a left lobe graft. Then in children's, what we can do is, again, to match the size, we can use a smaller size of the graft, left lateral segment or a monosegment graft can be used for smaller children's. So this is how the whole liver graft looks like. And so this is one of our own patient. She had a cadaveric liver transplantation. This is almost like 5 years ago now. and she had delivered a baby after the transplantation as well. And she had PBC, and she was literally wheelchair bound because of severe osteoporosis. And the life has dramatically changed for her after the transplantation. So this is just to show the split graft that is in a cadaver liver. You can split into two. You can give a portion to child, and you can use the one for the adult as well. If this liver, so normally splitting is done for a healthy liver, the liver quality should be good so that it can be divided into two. Then it can be in live donor setting. It can be either a right lobe graft or a left lobe graft. And as I said, in children, it can be either a left lateral segment or a reduced graft in order to accommodate into the abdominal cavity and the requirement as well. And it can be a monosegment graft as well. Okay, so repetition. So coming to disease donor liver transplantation. So just a brief about how this whole cycle about cadaveric transplantation works. And this is very important for you guys to know. So there has to be an awareness in general population about that organ donation can save lives. And we all have this duty to make people aware how brainstem declaration especially is done. So all the misconception about brainstem declaration should be removed. And then the declaration, after the declaration happens, then organ need to be retrieved, then organ need to be allocated to people, and now then the organ need to be transported, and the transplant happens. So in terms of assessment of a patient, so who can donate? So age is not a bar. Obviously, you need to look into cause of death. So recently, we used an 18-month-old baby's liver in our center about 2 weeks ago for a 7-year-old acute liver failure. So age is not a bar. So we used 14-month-old baby as well. And on the other side, we've gone up to 78 years in terms of using organ from a 78-year-old man as well. So age is not a bar, as long as the organs are good and other comorbidities and all are in favor. Okay, and then obviously you need to look at cause of death, comorbidities, how long they've been in ICU, their hemodynamic parameters, liver function test. I won't go into details of all this, but there is a thorough assessment being done so that you want to make sure that whatever you're going to do is going to work for the patient, and the whole exercise actually produces a good result as well. And so I already touched upon the allocation. Yeah. So organ retrieval and transportation is an important aspect. So what we are seeing now, and this is going to happen more and more common, you must be reading in the newspapers as well, that the organs have been retrieved in a different city and they've been transported because there is a limited time we have. So for liver, we say 12 hours, but we actually cut out on 8 hours. So once an organ has been removed from the body, it has to go and should be implanted within that duration in order for it to function. So you have to sort out all the logistics, especially if you're using it from different cities, that how you tie up with the airlines in order to get the organs in time for transplantation to happen. And there is a lot of push from Government of India, and they want organ retrievals to happen in second tier cities, smaller cities, so that they can be transported to these transplant centers in time. Okay, so this is just one of the example. This is again a few years ago where the organs were retrieved in Indore, and liver was flown to us in Delhi, and heart was flown to Mumbai. And it all started, the process started in the afternoon. By late evening, actually, we reached Indore, and we did the retrieval in the early hours of the morning. And we took the first flight from Indore to Delhi. And by 4 o'clock next day, we were done with the transplant. So this all is happening in the country. These are all things which are possible, and they are now happening on a regular basis. So it's not like 10 years ago, these things were unimaginable, but these are all happening now. And now more and more hearts are being transplanted, lungs are being transplanted as well. So all this activity is happening. Again, there is a lot of support in terms of creating green corridors, because we all know traffic is very bad, especially in Delhi. So the police administration, traffic control, they help a lot in terms of clearing up so that the organs can reach in time to us. So we've been around and we've gone to Indore, Jaipur, Patna, Chandigarh to get the organs from different places. And as I said, age is no bar. This is around 5 years ago. This 14-month-old baby actually donated organs. This was his liver, smallish liver. You can see it's just sitting on my palm. And that's the photograph after transplantation. Again, we've used 77 as well. This is the liver from 77-year-old. So coming down to live donor liver transplantation, where a part of the liver is removed. So who can be a live donor? So obviously it has to be a emotionally attached or preferably first degree relative. And the important thing is they should be emotionally attached and voluntary. So that process has to be established. They should be young, 18 to 55 years old. They should not have any systemic disease. They should be same or compatible group. Although we are now doing a lot of incompatible transplants as well. So we do titers and see how much is the mismatch, and then accordingly we can decide on that. So obviously we do extensive evaluation in terms of their liver volumes and anatomy. We do psychosocial evaluation and cardiopulmonary evaluation as well. So this is just the process of selection and outcome of potential live liver donors. We have published this before. If somebody is interested, they can go and read this paper. And it's the whole thing is a stepwise evaluation is done for the live liver donors, which start with basic investigation, viral markers, and then CT, MRI to assess their volumetries and cardiopulmonary evaluation. And then there is an authorization committee, which again is not no one from the transplant team is part of that committee. It's a legal committee which checks on all the document. And once they authorize and they're happy that there is no question involved, then the transplant actually proceeds and we do the transplant. Okay. So one of the limitations of live donor liver transplantation is there is only n number of patients who will be fit to donate their livers. So this is our own data where we validated around 460 donors. Out of this, only 136 could donate their organs. And that's because what we're seeing is an epidemic of fatty liver disease or other disease, other comorbidities, which actually precludes them from donating organ. So this is just to show why these donors got rejected, and you can see the majority of them were because of their liver parenchymal abnormality. That is, either they had steatosis, a state of hepatitis, or they got undetected diabetes or other parameters which came in, which were detected during the evaluation, and they could not proceed. So the message here is there is only limited number of live donors who can donate their organ. So we need to promote organ donation for more lives to be saved. And so live donor can only, there is a lot of limitation about the number of transplant which can be done through live donor transplantation. So my take home final slide, I think I've taken a lot of time as well. So CLD is common. Many will decompensate at some stage and will need transplant. So timing is very crucial here. So if there is delay, they spend a lot of time and money, and that doesn't really benefit in terms of themselves and their family as well. So timely transplant is very important. There are good long-term results of liver transplantation. There is no doubt about it. Again, in acute liver failure, timing is very important. Early referral should be done so that they can be monitored, and when they satisfy certain criteria, they can be transplanted. ACLF, more and more we are seeing ACLFs, and in grade 2 and 3, ACLF, they will need transplant. Again, they should be referred in time so that they can be evaluated, and when the need for transplant, it can be done in timely fashion. HCCs within criteria, and liver transplantation is curative. Even outside criteria, there are now good downstaging therapies become available, which can bring them into the criteria and they can be considered for transplantation. Organ donation need to increase in order to save more lives. LDLD is a good option, but there is a limitation in terms of how many patients we can offer. So we need to promote organ donation in order to save more lives. So this is the team. You can't have anything without team. We've got a big team as well. And teams can do wonder. And that is it. Thank you very much.